Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant by Fathom Pharmaceuticals.
Hello, I'm Dr. Joel Heidelbaugh, and I'm a clinical professor of family medicine at the University of Michigan Medical School in Ann Arbor, Michigan. And today our program is entitled Reflux is Everywhere, a Primary Care Guide to Managing GERD. I'm joined today by multiple colleagues who are experts in the field of GERD as well, starting with Dr. Chuck Vega, who's a clinical professor of family medicine and assistant dean at the University of California Irvine School of Medicine. He's also the director of the University of California Irvine Program in Medical Education for the Latino community. Kimberly Carter is Director of Clinical Education and Associate Professor of the Physician Assistant Program at Midwestern University in Glendale, Arizona. We're also joined today by Monica Nandwani, who's a Director of Advanced Practice Gastroenterology, and she's a nurse practitioner in the San Francisco Bay Area. And lastly, Mary Clark, who's a nurse practitioner with a specialty in GI motility at the University of California, San Diego Health in San Diego, California. So welcome to my colleagues. This program will include 5 distinct sections. First, I'll start with an introduction on gastroesophageal reflux disease, or GERD, discussing pathophysiology, epidemiology, and clinical presentation in primary care. The second section will be given by Mary Clark and Monica Nandwani on diagnostic criteria and initial assessment. The third section will be Dr. Chuck Vega talking about management of GERD. And the fourth section will be Kimberly Carter talking about the introduction of a new class of medication called PCABs, or potassium-competitive acid blockers. Lastly, I'll conclude with the last segment on management of refractory GERD and highlight a patient case. So let's begin with the first section, introducing GERD. So many of us see GERD in our practices, and likely many of us see many different levels of symptomatology with GERD across our patient spectrum. So GERD we generally think of in several different categories, and it generally becomes GERD, or gastroesophageal reflux disease, when it causes troublesome symptoms and significant regurgitation or heartburn for patients. Most cases are going to be what we call NERD, or non-erosive GERD. And we worry about the development of potentially erosive complications with erosive esophagitis or erosive GERD. So when we look at the classification and risk scheme for GERD, about 90% of the cases we encounter in our practice are going to be non-erosive cases. A few will progress to erosive esophagitis, and we classify this according to the Los Angeles grade classification, and I'll have some more detail on that in a minute. Ultimately, we also worry about the development of more advanced disease from erosive esophagitis to Barrett's esophagus, and rarely, but certainly more worrisome, the development of esophageal adenocarcinoma. So what's the common clinical presentation of our patients with GERD? Well, most patients are going to present with what we call the cardinal symptoms of heartburn, acid regurgitation, and sometimes even esophageal chest pain. Less common symptoms can include dysphagia, certainly bleeding or hematemesis would be very worrisome. But some patients with chronic cough or asthma, chronic hoarseness, chronic laryngitis, maybe tooth erosions, or even chronic belching or bloating may have GERD. And oftentimes we can manage most of these patients in our primary care practices. But as we go throughout each section of this presentation today, we're going to be highlighting what the hallmark symptoms will be noted as alarm symptoms, and also when we would consider referral to our colleagues for endoscopy or for gastroenterology evaluation. So any GERD symptoms combined with alarm symptoms that might be suggestive of advanced disease, such as unintentional weight loss, unexplained anemia, progressive dysphagia, or hematemesis, those symptoms would prompt a referral. Also, if patients don't respond to standard pharmacotherapy. So this slide highlights the Los Angeles classification of erosive esophagitis, and it's graded from A through D based on severity. This schematic highlights some endoscopic pictures, and in the clinical world or in our practices, we probably won't be thinking about the severity of this as much. These are endoscopic findings, but I think it's important to highlight this because you will see patients who have erosive esophagitis, and it's important to ultimately know that based on symptom severity and endoscopic findings. So let's highlight the various etiologies of GERD. Certainly, obesity is a risk factor through increased intra-abdominal pressure, hiatal hernia, certainly increased estrogen levels, increased bile acid, and pancreatic enzymes. Patients who smoke tobacco experience reduced acid clearance time in the esophagus, and it also reduces pressure in the lower esophageal sphincter, which can promote heartburn and regurgitation and lead to esophageal symptoms and erosions. We know that some patients will have a genetic predisposition to developing GERD. We know that alcohol and various elements in the diet, perhaps caffeine, may precipitate symptoms in patients with known GERD, but a causal association has not been very well established. So most of the time in our clinical practices, if a patient presents with signs or symptoms of GERD, it's important to take an appropriate dietary history and social history, as patients can be able to best tell us what types of lifestyle acts may predispose them or actually cause symptoms of GERD. There's also some evidence that eradication of H. pylori infection may predispose patients to GERD or even worsen GERD symptoms. And in a few minutes, I'll talk about the difference between GERD and dyspepsia and why that's important. So dyspepsia is commonly classically confused with refractory GERD, and it's often the most common cause of GI referral from primary care. It's important to try to make a differentiation between GERD and dyspepsia. So GERD is typically classic heartburn and regurgitation that may be after a meal or after drinking something that may incite those symptoms. And often dyspepsia is limited to stomach pain that is not necessarily esophageal pain and doesn't have the classical symptoms of heartburn and regurgitation. And again, these can be difficult to tease out in clinical practice. About 60% of cases of dyspepsia are due to peptic ulcer disease. It should be important to ask patients about NSAID use and aspirin use, even enteric-coated aspirin use. And H. pylori can certainly cause dyspepsia and ulcer disease, even though the incidence is decreasing. About 40% of cases are due to functional dyspepsia, and functional disorders have this interplay between a disorder of gut-brain interaction, and oftentimes there may not be any identifiable etiology, and these can be very challenging to treat. They can overlap with other, both upper and lower gastroenterology diagnoses. And to date, there's not really effective proven pharmacotherapy. So the clinical presentation of GERD in primary care is extremely important to try to elucidate early on. Again, through a careful history of exacerbating factors, time of day that this may cause symptoms for patients, whether it's during the day or even at night when they lie down. And it's very important to detect GERD early and make an accurate diagnosis, to be able to think about what patients you may trial for empiric therapy with anti-secretory therapy, and we'll get into that in the next sections. Or if a patient has specific alarm signs and symptoms, certainly considering early endoscopy and or referral to a gastroenterologist to identify and treat complications if they are present. So thank you for participating in this section, and please continue now on to the second section on the diagnostic criteria and initial assessment of GERD with my colleagues Mary Clark and Monica Nandwani.
Hello, I'm Monica Nandwani, a gastroenterology nurse practitioner in the San Francisco Bay Area, and joining me today is Mary Clark, a gastroenterology nurse practitioner from the University of California, San Diego Health System. Welcome to the second section of our program on gastroesophageal reflux disease entitled Diagnostic Criteria and Initial Assessment. So, Mary, can you tell us about how to recognize the clinical symptoms in GERD in order to make a clinical diagnosis?
Yeah, so let's talk about that. There's a criteria of certain diagnoses or certain symptoms rather that are typical in patients with GERD, and then there's some other symptoms that are less likely to occur. So your classic or typical symptoms of GERD include heartburn. That's that burning sensation under the breastbone. Regurgitation, which is this effortless presence of a sour, bitter gastric content into the mouth. And then the third classic symptom would be that esophageal chest pain. That's a retrosternal chest pain, doesn't tend to radiate. So when a patient comes in and complains of one or all of those symptoms, we really think that this patient these symptoms sound consistent with GERD. The less likely symptom may be belching, because with acid reflux, this can cause excessive belching because the patient continues to swallow repeatedly to try and clear reflux. And so this can lead to swallowing air, and this is where the belching comes from. There's a very low likelihood that chronic cough, asthma, and wheezing may be caused by GERD. And so atypical symptoms, voice hoarseness, globus, which is a lump or swelling sensation in the back of the throat, nausea and abdominal pain, and dyspepsia are less likely to be GERD, but still may warrant a workup.
Thank you, Mary, for that very comprehensive review of the typical and atypical symptoms of GERD. Can you tell us what the guidelines recommend regarding the diagnosis of GERD?
Yeah, so when we look at guidelines, one of the guidelines we use is the Lyon Consensus 2.0, and they differentiate between typical and atypical symptoms of GERD, and then what is the approach. So if patient presents in primary care with heartburn, regurgitation, or the esophageal chest pain, the first step would be to try an empiric trial of anti-secretory therapy. This would be your proton pump inhibitors, even your H2 blockers. And the idea is to put a patient on that for 8 weeks to see if they respond to symptoms. If they respond or have a partial response and you take them off and the symptoms come back, that warrants further testing, such as an endoscopy, wireless pH monitoring, or pH impedance monitoring. If they have an atypical symptom such as belching, this may indicate you may proceed with endoscopic testing, again, the pH impedance testing. And then with other atypical symptoms such as chronic cough and asthma, this is where it would be acceptable to move forward with endoscopic testing and more to rule out that reflux is the basis for their symptoms of such as chronic cough, asthma, wheezing. With your atypical symptoms such as globus, nausea, abdominal pain, and dyspepsia, a lot of times the underlying cause is not GERD. So these patients can be sent to gastroenterology where we can evaluate further these symptoms and determine if they do need testing or if there's more of an adjunct approach for looking at throat symptoms that may be caused higher up in the GI tract and the larynx and not so much in the esophagus. So the other guidelines we look at is the American College of Gastroenterology, their clinical GERD guidelines diagnosing GERD that are pretty consistent with a Lyon consensus. Again, looking at those patients with the classic heartburn, regurgitation, and the esophageal chest pain, recommend an 8-week trial of empiric proton pump inhibitors, and that's part of the anti-secretory regimen. And you take these before meals, 20 to 30 minutes before meals. When you try and discontinue these medications, if the symptoms come back, then that warrants further testing, moving on to an endoscopy. But for a patient who has chest pain without heartburn, you want to make sure they've undergone an evaluation to exclude cardiac disease and then can move on to objective testing for GERD. So when we're trying to conclude if patients really have good conclusive evidence for GERD, the idea is after they've tried the 8-week trial of the anti-secretory therapy, at least 2 weeks after stopping that, you'll consider doing an endoscopy. And this is when you send them to gastroenterology, and our gastroenterologist will perform the endoscopy, and they look for things like esophagitis. There's a classification for esophagitis, A, B, C, and D. A is very mild. But B, C, and D indicates more mucosal breaks and a higher circumference of the tissue that is affected in the esophagus. So that is a good conclusive evidence for GERD. A peptic stricture is also evidence of GERD. This is an end result of chronic reflux, creates a scarring and narrowing in the lumen of the esophagus. Biopsy-proven Barrett's esophagus. So during the endoscopist can perform some biopsies to determine if the tissue actually has changed in the esophagus to represent chronic exposure. 24-hour pH testing with a score of greater than 6% total acid exposure time, or a 96-hour wireless pH testing with greater than or equal to 2 days of greater than 6% total acid exposure time, or greater than 80% reflux events in a 24-hour period. And these are all diagnostic criteria we use in GI to determine if patients truly have an excessive amount or if they fit within the norm. The alarm features for patients who present with what you may consider GERD would be dysphagia, difficulty swallowing. Patients with GERD might have difficulty swallowing, but this is not a cardinal symptom of GERD, and this does warrant further investigation, as does odynophagia. Odynophagia is that pain with swallowing. Early satiety is another alarm symptom that can indicate something a little bit more serious, whether it's underlying esophageal motility disorder that is not GERD. A GI bleed is definitely cause for concern and warrants further investigation. And then a patient who says that they're vomiting, you want to distinguish between, is it true emesis? Was it maybe preceded by nausea or upset stomach? Or is this where food slides down, and like we talked about in the beginning, this effortless presence of sour or bitter gastric content into the mouth? And then chest pain, as was mentioned before, you want to determine if this is cardiac versus esophageal. And if you're unsure, this is when we generally refer the patient to a cardiologist, or at least have the patient undergo an echo and an EKG that may be worked up by their primary care. The dysphagia, odynophagia, early satiety, GI bleed, and vomiting, we would recommend an upper endoscopy.
Thank you, Mary, for that very thorough overview of the Lyon Consensus, the American College of Gastroenterology guidelines for GERD, and for reminding us what the alarm symptoms are that warrant further evaluation. Speaking of further evaluation, can you let us know how does one test for gastroesophageal reflux disease and what the different testing modalities available are?
Yeah, so for GERD testing, particularly if we're suspicious that they have the classic symptoms, but they may also have some other the atypical symptoms, an upper endoscopy is warranted. The upper endoscopy can look for esophagitis, which is that inflammation in the esophagus, and again, that's graded A through D. It's an LA grade score. They can look for stricture, particularly the peptic stricture, as opposed to an esophageal stricture that may be caused by something underlying that's mimicking GERD, such as achalasia. And they'll look for those features of Barrett's esophagus. A lot of times the endoscopist will comment on seeing salmon-colored mucosa, and so biopsies are then taken to determine if it shows atypical cells such as goblet cells, intestinal metaplasia cells, or dysplasia cells that help conclude the diagnosis of Barrett's esophagus. pH testing is another opportunity to look for that excessive amount of acid coming from the stomach into the esophagus. This can be done either by a 24-hour pH impedance probe. This is a probe put through the nose, measures how much acid is coming up, and can identify acidic, weakly acidic, and non-acidic reflux events. Additionally, the alternative would be a 48 to 96-hour wireless pH test. This is a chip that's implanted into the distal part of the esophagus during an endoscopy. The patient goes home with a pager, presses a button every time they feel a symptom. It transmits this wireless signal to that pager, and we again can identify how often is the patient refluxing. Now that we discussed how to recognize and assess symptoms of GERD, we understand that symptoms could be atypical, which makes the diagnosis difficult. Monica, what's on the differential?
Thank you for that great question, Mary. And when patients present with these symptoms of GERD that you mentioned, the differential diagnosis can be quite broad. Things to consider in the differential include infectious esophagitis. So, for example, if your patient presents with heartburn, reflux, and perhaps adynophagia or pain with swallowing, if they have a history of immunosuppression or maybe immunocompromise, then you may want to consider a differential diagnosis of infectious esophagitis, such as Candida esophagitis. Additionally, another thing to consider when taking a history is, could this potentially be pill esophagitis or medication-induced esophagitis? Frequently prescribed medications associated with pill esophagitis include antibiotics, which can account for up to 50% of reported cases in younger adults. Tetracyclines are the most common class of antibiotics implicated. Other classes of medications, such as nonsteroidal anti-inflammatory drugs and bisphosphonates, can also be common culprits for pill esophagitis. For your patients who might have a history of allergic disorders, such as asthma or eczema or seasonal allergies, and might present with difficulty swallowing or dysphagia and heartburn symptoms, another differential is eosinophilic esophagitis, which is kind of like an allergic disorder of the esophagus. Other differential diagnoses to consider include esophageal dysmotility. So, Mary, for example, you mentioned achalasia earlier on, where there is no normal peristalsis in the esophagus, and the lower esophageal sphincter does not relax on swallowing and can produce symptoms of heartburn, reflux, difficulty swallowing. Other differential diagnoses include esophageal or gastric neoplasms. For those patients that might have undergone the pH testing, Mary, that you had mentioned earlier, a differential of reflux hypersensitivity can be considered. So those are the patients who might have normal or physiologic acid exposure, but perhaps might have hypersensitivity to the physiologic reflux events, as opposed to patients with functional heartburn. And those are patients who on pH testing have normal acid exposure without any symptom correlation. Other differential diagnoses to consider, especially if the patient presents with symptoms of early satiety, perhaps nausea or vomiting or abdominal pain, include functional dyspepsia, peptic ulcer disease, and gastroparesis. Gastroparesis is delayed emptying of the stomach in the absence of an obstruction and can be seen in patients who have diabetes or might be on any medications that slow gastrointestinal motility, such as opiate medications. Other differential diagnoses include a paraesophageal hernia. So could this be a mechanical cause contributing to symptoms of heartburn and reflux? Rumination is a disorder of gut-brain interaction characterized by effortless regurgitation of ingested food into the mouth after most meals. And of course, in patients who present with chest pain, it is critical to rule out a cardiac cause, as one person dies every 36 seconds in the US from coronary artery disease, leading to 1 in every 4 deaths. So it's important to rule out a cardiac cause in patients who present with chest pain. In summary, classic gastroesophageal reflux disease symptoms are heartburn, which is the substernal burning sensation, and regurgitation, or the effortless return of gastric contents upward toward the mouth. Chest pain can be indistinguishable from cardiac pain and may present in conjunction with heartburn and regurgitation, and it is absolutely critical to rule out a cardiac cause for chest pain before considering gastroesophageal reflux disease as a contributor. Any alarm symptoms such as dysphagia or difficulty swallowing, unintentional weight loss, or evidence of GI bleeding absolutely warrant further evaluation with upper endoscopy. And finally, a GERD diagnosis is really based on a combination of symptoms, endoscopic evaluation, reflux testing, and/or response to therapy. Thank you, Mary, for this great discussion, and thank you all for your participation in this section. Please continue on to watch the third section on management of GERD with Charles Vega.
Hello, my name is Dr. Chuck Vega, and I'm a clinical professor of family medicine at the University of California at Irvine, where I also serve as assistant dean in the School of Medicine here. I'm delighted that you're joining me today for the third section of this series, and I'm covering the management of GERD. So when we think about managing GERD, this is something I do in my practice all the time, And it starts off with lifestyle changes and behavioral changes. So certain things such as limiting food and not eating, especially before bedtime for folks with nighttime GERD. So I try to, give them a 4-hour break, stopping cigarette smoking, and elevating the head of the bed. These are relatively easy interventions that still can work. Even in more severe cases, I still recommend using those interventions for folks. I think the one that I work on over time that is the most effective is weight loss. So while that's more of a long-term project, I find that it really can make a big difference in relieving symptoms of GERD and preventing more severe esophagitis as well. So that's first and foremost. Many of my patients have already tried before they see me simple interventions that are available over the counter, like antacids and histamine 2 receptor antagonists. And those are good drugs. I think it's perfectly fine, particularly for somebody with intermittent GERD, to use them. There was a systematic review and meta-analysis looking at antacids. The absolute benefit in terms of symptoms was fairly small, 8%, but the number needed to treat with antacids to improve one case was 13. That's a pretty low number. And for a drug that's generally well tolerated and very inexpensive, I think that they certainly have a role. Histamine 2 receptor antagonists also have a role. There, the absolute benefit in terms of symptom relief was a little bit better, 10 to 12%, with a number needed to treat of 9, rather. And so, therefore, I think those are both options. And for patients with more mild disease, and especially intermittent disease, because they work quickly, that's one of their big advantages. Absolutely good choices. But most patients have more persistent symptoms, they have more chronic symptoms, and we need to reach for something else. And usually the first thing on our agenda to reach for is a proton pump inhibitor, or PPI. PPIs are more potent in terms of acid reduction, but the problem is they're going to take a day or two to work. So that's the problem. For on-demand treatment, they're just not that effective. And we know they have other limitations as well. So, for example, they are prodrugs. So they need to have gastric acid present in order to function effectively. And they only work on parietal cells that are actively secreting acid. So during fasting times, only about 5% of your pumps and your parietal cells are actively secreting acid. But with meals, it's 60 to 70% of your pumps are actively secreting acid. So there are prodrugs. They should be taken before the first meal of the day, which is inconvenient for some folks. And they have a fairly short plasma half-life as well. So that's the thing. While they are effective at acid reduction, they only work for 2 or 3 hours. And remember that in terms of proton pumps, are constantly being replaced. About 25% are replaced every 24 hours. Finally, a drawback to PPIs is their potential drug interactions through metabolism through the CYP2C19 enzyme. So there are some guidelines for folks with more significant GERD, and generally what I will follow these guidelines from the American Gastroenterological Association for the application of treatment. It does focus on PPIs. So for folks with typical GERD symptoms, they've tried lifestyle changes and they're still having symptomatology. It's appropriate to start a single dose PPI in a trial for 4 to 8 weeks and then assess their response. For those folks who have a complete symptom relief of GERD, then it's reasonable to step down therapy. And so I try to wean off the drug. And again, we're still focused on weight loss. We're focused on lifestyle changes. Those things are going on. And hopefully patients don't need PPI, or they need them on an intermittent basis. For patients who have more incomplete relief after 8 weeks, it's best to do an EGD, so send them for upper endoscopy. And ideally, you want to do that after they have been off of medications, off PPI therapy for 2 to 4 weeks. In cases that have a normal upper endoscopy or a very low grade of esophagitis, like a grade Los Angeles grade A, there's a couple different options. One is those are patients who may need to be monitored for with a pH probe, looking for GERD to make the diagnosis. And the other thing is start rethinking whether this is actually reflux, or perhaps we're missing something else. Maybe there's an alternative diagnosis for their symptomatology. If they have more significant esophagitis present, then GERD is confirmed, and you're going to continue your proton pump inhibitor more indefinitely, which is a challenge because there are many associated possible side effects from PPI therapy over the long term. And so whether we're thinking about fractures or dementia or celiac disease, various vitamin deficiencies, a lot of those are associations. They're not very well established in clinical practice, and therefore they're not very clinically meaningful. I think the one that's most proven is PPIs do increase the risk for lower GI infections, particularly with C. difficile. But that, if you look at a community sample of adults, is actually a pretty rare event. So of course, we always want to practice good stewardship. I would not use PPIs in somebody who would not benefit from them in any way. They're not symptomatic. They don't have, esophagitis. They don't have, Barrett's esophagus. No, I would certainly try to wean them off the drug. But at the same time, for those patients, and I have a good number who need the drug chronically, I think that generally the benefits outweigh the risks for those patients. So that's another thing to consider. So overall, in my very brief review here, lifestyle changes are foundational. So simple things like raising the head of the bed, avoiding meals before bedtime, and especially weight loss are critical. For patients with occasional symptoms, absolutely antacids, histamine 2 receptor antagonists can work and are often effective. Proton pump inhibitors are necessary for many patients who with symptomatic GERD. But don't forget that if they only have a partial response, which is pretty common, that's when we want to consider upper endoscopy and the involvement of a specialist, and that will give us a lot more information in terms of their grade of esophagitis. While we are concerned about the long-term side effects of any drug, I think PPIs are generally safe and very well tolerated. So for my patients who need them long-term, they get them long-term. And therefore, they have reduced symptomatology over time and better functionality as well. Hopefully you found this section helpful. I would strongly encourage you to now move on to the fourth section in our series, introducing potassium-competitive acid blockers, or PCABs, and that's presented by Kimberly Carter. Take care.
Hello, I'm Kimberly Carter, and welcome to the fourth section titled Introducing Potassium-competitive acid blockers, referred to as PCABs. During this segment, we will discuss the mechanism of action of PCABs, review efficacy and latest data, and then identify some clinical applications and opportunities for PCABs in GERD. So let's begin with an overview of PCABs. So PCABs are actually not new. They've been around since the 1980s. However, earlier drugs in this class were discontinued due to hepatotoxicity. But over the last decade, they have been largely studied in Asia, and we now have a single agent, vonoprazan, with FDA approval. So let's discuss some of the pharmacologic features of PCABs. So PCABs are acid-stable medications and do not require enteric encoding. So this is unlike PPIs, which are acid-label and require that enteric coating, which can delay absorption. PCABs have an optimal effect from the first dose, so beginning to increase that intragastric pH within a few hours. PCABs also have a longer half-life, roughly 6 to 9 hours, compared to PPIs of 1 to 2 hours. PCABs are active drugs, not prodrugs, and they offer meal-independent dosing, so they do not need to be time dosed around meals, as we would see with PPIs that need to be administered about 30 to 60 minutes before a meal. Another interesting feature of PCABs is that they bind both active and inactive proton pumps, and they bind ionically reversibly to that pump. So they can bind to the pump, deactivate the pump, detach, and then bind to a new pump. And then lastly, PCABs are not metabolized primarily by CYP2C19. And this is important because we know that CYP2C19 can be associated with genetic variances, which can influence metabolism, efficacy, and tolerability. So this illustration depicts the mechanism of action of PPIs compared with PCABs. So you can see upon activation in acid, the PPI inhibits that hydrogen potassium exchange, versus PCABs competitively blocking that potassium. So let's review the current status of PCABs in the United States. So we do have a single agent vonoprazan with FDA approval for multiple indications: H. pylori infection as part of dual or triple therapy, erosive GERD, and most recently approval for non-erosive reflux disease, so NERD. And then we'll talk a little bit about some of the studies associated with tegoprazan and fluoxaprazan with regards to erosive esophagitis and non-erosive reflux disease. So let's take a look at our first study here. This was a phase 3 non-inferiority study evaluating the efficacy of vonoprazan 20 milligrams compared to lansoprazole 30 milligrams in healing erosive esophagitis at week 8. And there are 3 data sets here to be aware of. The first set relates to patients with all grades of esophagitis, A, B, C, and D. The second set are patients with more severe forms of esophagitis, LA grades C and D. And lastly, the 24-hour heartburn-free days. So if we take a look at that first set, in all grades of erosive GERD, 93% of those patients achieved healing with vonoprazan compared to 85% taking lansoprazole. So about an 8% therapeutic gain there. In the subgroup population of those patients with LA grades C and D, 92% achieved healing with vonoprazan versus 72% taking the lansoprazole. So a 20% therapeutic gain there. And no major differences in the symptomatic improvement or the 24-hour heartburn-free days. So really, in summary, vonoprazan was non-inferior to lansoprazole in healing erosive esophagitis, with a more pronounced benefit in those patients with more severe forms of esophagitis, LA grades C and D. This was a study assessing the efficacy of vonoprazan for the treatment of heartburn in NERD. And so these were patients that were randomized either to placebo or 10 milligrams of vonoprazan or 20 milligrams of vonoprazan. And what we can see is that a greater percentage of the patients achieved 24-hour heartburn-free days on vonoprazan compared to placebo. Now, there were no major differences between the 2 doses of vonoprazan, 10 or 20. It was roughly about 44%. But compared to placebo of about 28%, there was a 17% difference there. Another interesting feature here, though, is the benefit appeared to begin as early as that first day of therapy and persisted throughout that 20-week extension period. This was another study assessing the efficacy of vonoprazan on-demand treatment for symptomatic NERD. And so again, these are patients randomized to vonoprazan 10 milligrams, 20 milligrams, 40 milligrams, or placebo. And what we can see here is that all doses of vonoprazan demonstrated a greater proportion of complete and sustained relief of heartburn within 3 hours, particularly within that 1 hour of dosing, and no serious treatment emergent adverse events were reported. This is another phase 3 non-inferiority study evaluating the efficacy of tegoprazan versus esomeprazole in healing erosive esophagitis at week 8. And so again, patients randomized here to tegoprazan 50 milligrams, tegoprazan 100 versus esomeprazole 40 milligrams. And we can see that both doses of tegoprazan were non-inferior compared to esomeprazole. We can see that tegoprazan was well tolerated, and the incidence of adverse events was not bothersome and comparable amongst all groups. This was another study that assessed the efficacy of tegoprazan versus placebo in non-erosive reflux disease. So again, 2 data sets here, a full analysis set and a subgroup analysis in patients with more severe heartburn. And again, randomized to placebo, tegoprazan 50 or tegoprazan 100 milligrams. And we can see that the tegoprazan treated groups demonstrated a greater proportion of heartburn-free days compared to placebo in both sets, with a more pronounced difference in that subgroup analysis. So the full analysis, about a 10% difference versus the subgroup analysis, about a 20% difference there. And then lastly, this was another phase 3 non-inferiority study evaluating the efficacy of fluoxaprazan 40 milligrams compared to esomeprazole 40 milligrams in healing erosive esophagitis at week 8. And we can see here that fixoprozan was not inferior to esomeprazole in healing at week 8, and no serious treatment emergent events reported. So let's briefly talk about the clinical applications and opportunities for PCABs and GERD. And it's really important here that we consider the umbrella of GERD and the phenotypes of GERD to include both erosive disease and non-erosive disease. Yes, we're going to have a small percent of that population who's going to have erosive disease, LA grades A, B, C, D. They may have stricture formation. They may have Barrett's esophagus. But the majority of the patients that we're treating are going to have that NERD, that non-erosive reflux disease. So when you consider the mechanism of action of PCABs to be active, stable, active drugs, they're stable in acid, they offer meal-independent dosing. This allows for a very rapid, robust, durable acid suppression therapy. And that certainly lends an opportunity to bridge that unmet therapeutic demand and potentially improving compliance and tolerability. This has to, though, be weighed with cost and coverage and availability, and recognizing that PPIs and H2 receptor antagonists available over the counter. And of course, further studies evaluating the long-term safety data. But our studies do support potential benefit for severe and non-healing, difficult to treat GERD. So those patients with erosive esophagitis, LAC, LAD, who have failed optimized PPI therapy. It may be beneficial in patients with esophageal or gastric motility disorders, particularly patients who may have scleroderma. And then potentially in patients with PPI refractory GERD or intolerance to PPI, or perhaps poor candidates for anti-reflux intervention. I think the caveat here being in the understanding that these are patients that have documented acid reflux on ambulatory testing as opposed to this uninvestigated heartburn. And then when we consider further research, certainly the on-demand administration of PCABs for NERD, and not just comparison to placebo, but how they'll compare to PPIs with other potency and dosing, and of course our H2 receptor antagonists. And then we think about, the algorithm, the AGA and the ACG algorithm in patients presenting with classic GERD symptoms. Our empiric trial is with a PPI, but we may see where, given the mechanism of action of PCABs, could this become an empiric test for patients? So certainly opportunities to consider on the horizon. So again, thank you for participating in this program, and please continue on to the last section, Managing Refractory GERD with Dr. Joel Heidelbaum.
And now let's move on to our last section on managing refractory GERD. Hello again, I'm Joel Heidelbaum, clinical professor of family medicine at the University of Michigan. This slide is a nice summary schematic that we developed at my institution about a decade ago that I still use in my clinical practice. And just to highlight, we start with a patient with heartburn or regurgitation symptoms. We talk about initiating treatment. Again, these medications are over the counter, and often initial therapy can be patient-directed, either with a PPI or an H2RA. And if a patient has good initial response and they're symptom-free, try to maintain the patient on the lowest effective dose with on-demand therapy. If they are at higher risk, consider screening for Barrett's esophagus. If they don't have a good initial response, considering step-up therapy with maximum dose, PPI, or consider a PCAB. If there is not adequate response, think about going back and asking yourself, do we have the original diagnosis? Do we have an accurate diagnosis? Consider confirming the diagnosis with a 24-hour pH probe or endoscopy. And certainly if alarm symptoms are present, or if there's a treatment failure after 8 weeks on a PPI, absolutely these patients should receive upper endoscopy evaluation. So let's talk about atypical GERD, because we will see patients in our practices that have chronic cough with a negative pulmonary or ENT workup. We'll see patients with chronic laryngitis, chronic hoarseness, again with negative workups. And oftentimes these patients may have chronic and untreated GERD. So aggressive acid reduction using PPIs twice daily before meals for a child of 3 to 4 months is still the standard treatment, and may be the best way to demonstrate any type of causal relationship between GERD and the extraesophageal symptoms. To date, randomized trials have not shown significant benefit for twice-daily treatment for laryngeal symptoms. Laryngeal reflux is out of the scope of this particular presentation today, but this is also a known therapy. And in patients with moderate to severe persistent asthma and symptoms of GERD, evidence shows that BID PPI therapy for 24 weeks reduces asthma exacerbations and quality of life. It wasn't necessarily found to reduce all the symptoms, use of albuterol rescue inhaler, or pulmonary function. And patients with chronic cough also have a high likelihood of GERD. And when they're prescribed a trial of anti-secretory therapy, it often provides benefit even though they may not have reportable GI symptoms. So again, thinking back, not all patients with GERD are going to have those classic symptoms of heartburn and regurgitation. So in patients with chronic cough, chronic hoarseness, chronic laryngitis, even asthma with unremarkable pulmonary function tests, think about GERD. And lastly, relative to atypical chest pain or non-cardiac chest pain as formerly known, PPI therapy has been shown to reduce various symptoms and can also be used as a diagnostic test in identifying abnormal reflux. So follow-up and surveillance is very important. If a patient has symptoms that have remained unchanged with a prior normal endoscopy, repeating endoscopy for up to 10 years probably is not going to offer you any benefit. Again, remember that when a patient undergoes upper endoscopy, you're not going to actually see reflux. What you're going to look for is complications such as erosions, Barrett's esophagus, strictures, etc. Now, in many centers, there's patient-directed direct access endoscopy, and we've had patients actually refer themselves for endoscopy. And that's something I think that's important to talk about patients with relative to ongoing follow-up with symptoms in primary care practices, but limiting any potential risk of unneeded procedures. Patients with warning signs and symptoms suggesting complications absolutely should be referred to a gastroenterologist for close ongoing follow-up and management. And further diagnostic testing, either with upper endoscopy or pH monitoring, should be considered in patients who don't respond to acid suppression and in patients with a chronic history of GERD who are at risk for those complications. We've suspected that chronic reflux plays a major role in the development of Barrett's, but we don't know if outcomes can be improved with surveillance and medical treatment. Nonetheless, these patients are still going to remain on anti-secretory therapy and followed very closely through an endoscopic surveillance program. We do know that anti-secretory therapy reduces the need for recurrent dilation from esophageal stricture formation. So now let's look at a patient case. And in this particular case, we have a 46-year-old female, history of obesity, inactivity, tobacco and marijuana use, moderate alcohol use, hypertension, and prediabetes. And she presents for an evaluation for poorly controlled GERD symptoms of heartburn and the recent development of chronic sore throat and occasional nighttime wheezing, with a negative workup for any acute viral upper respiratory tract illness and a negative workup for asthma. She's tried various dietary modifications. She's tried over-the-counter PPIs, and she's tried nighttime H2RA before bed with minimal symptomatic relief. So how would you handle a patient like this in your primary care practices? Well, what we know is she has refractory GERD. She's tried maximal medical therapy through anti-secretory medications, and she has extraesophageal symptoms, which are not only bothersome, potentially risky relative to the development of complications. So she would be a suitable candidate for a PCAB to control her symptoms because her symptoms have not been adequately controlled with other medications. I would recommend a trial of vonoprazan, and I would recommend this after her PPI failure, especially if she's still symptomatic. She will also need close follow-up with primary care and likely gastroenterology as well. So in summary, when we think about referral and long-term management of GERD, again, we know GERD is the most common presenting complaint in primary care that leads to a GI referral. And again, it can be very difficult sometimes to distinguish between GERD and dyspepsia. Often patients will be referred for upper endoscopy when anti-secretory therapy has failed. It's important to refer for alarm symptoms and to monitor for alarm symptoms very carefully. And long-term management and follow-up will ultimately depend upon management with medications, lifestyle modifications, and surveillance for the development of extraesophageal symptoms. So in terms of diagnosing and recognizing the differential diagnosis of GERD, we've highlighted many ways to think about that today, thinking about not only a potential overlap between GERD and dyspepsia, but also extraesophageal symptoms. And we think about these all the time in primary care practices. When we think about selecting appropriate pharmacological treatments for GERD, given that H2RAs and PPIs are over the counter, most patients are going to commence with self-directed therapy, which is certainly reasonable. I think it's a good habit to ask patients if they are taking over-the-counter medications, because we often focus just on prescription medications, and many patients are going to get these over the counter. In terms of long-term management of patients, it's important to think about shared decision-making models in terms of further workup, but also what medications we prescribe. For years, there's been concern about overprescription or overutilization or long-term utilization of H2RAs and PPIs. And I think the evidence is pretty clear at this point that these medications offer an excellent therapeutic efficacy and safety profile. So I'd like to thank my colleagues Kimberly, Mary, Monica, and Chuck for their participation in this program and their excellence in presenting very important and clear material today on how to help guide primary care practitioners in diagnosing and managing GERD in their practices. And I'd also like to thank our audience today for participating in this activity. At this time, please continue on and answer the questions that follow and complete the evaluation.